All right. Thank you, Colton. Good afternoon. We have a quorum, so I will call to order the Kansas Board of Nursing Practice Committee. I am Michelle Terry, acting as chair in place of Lori Owen, who is traveling today. So there was no on-site packet, additions or revisions to agenda. We want to take a look at our agenda. Any changes? How about announcements? Easy. Let's next look at approval of minutes beginning on page 3 of your packet. Any additions or corrections? Entertain a motion.
Madam Chair, I motion to move to approve the minutes from March 25th, 2025, Practice Committee as written.
Thank you, Melissa.
Second.
Thank you, Patty. There's been a motion and a second. Any discussion? All in favor say yes.
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 Decline? No. Abstain? Thank you. Motion passes. So next, we have the consent item agenda practice calls report, and that begins on page 6 of your packet. Linda, did you want to add any flavoring additions to this?
No, Madam Chair, it's still running pretty fast and furious.
If no changes or discussion, I would entertain a motion.
Madam Chair, I move to approve the consent item agenda, which included practice calls report.
Thank you, Patty. Is there a second?
I'll second.
Ms. Melissa. There's been a motion and a second. Any discussion? All in favor say yes.
Yes.
Opposed, no. Abstain? All right, now let's get into unfinished business. The first one will be a presentation by the Kansas School Nurses Organization, and we've got Angela Anderson and Tara Harmon Moore on the line. You ladies hear us?
I think it will take a second for him to get him in.
I'm sorry, we're trying to move Tara over, correct?
And this begins on page 8 of your packet.
We're moving Tara over, correct?
Yes, Tara and Angela.
I don't see an Angela, but I do see a Tara.
Okay.
Angela's already up.
Oh, I see that now.
Hi. Thank you, ladies, for being here. This part is as follow-up to our last meeting. And so I'll turn it over to you, ladies.
Okay, so I'm just going to, I don't know what you prefer for me to do. I took notes this time to be more prepared for you, specifically what changes were made. There was in the email, there was it was mentioned that there might be some recommendations, and the last time that we had met, it was recommended to add information about the G tubes, medication administration there through the G tubes, and I did add that information, which should be on page 29 in the guidelines. I went through kind of explaining the different methods, supplies, safety considerations, and then links to some resources. Mostly that from Show Me Health from Missouri because they had some really great resources, videos available. So I specified that into that. So that's the only thing that I've added since the last time we had met. I did update to make sure that the table of contents was good, should be working for you guys. Would you like me to go over any other changes that had been made from the previous revisions? I don't know if everyone was here last time.
Yeah.
Please.
Yeah, Melissa, did you have some
Oh,
questions?
I had some questions, so I wasn't able to attend the last meeting in March. But as I was looking at so this document is for the state of Kansas, correct?
Yes.
Only for the state of Kansas school nurses. Okay, so under the purpose in the first line, I was just looking at like Kansas statute and regulations, and since we've had that Senate Bill 287, specific for, I don't know if you'd be open to adding consent and medication administration in school because of that bill, because there are some specific carve-outs. That bill is allowed to kind of go forward without consent, some screening programs and those types of things. In addition to that, when I was looking at this on page, sorry, let me get there. Just a second. Page 23. You still have under the physician, parent, legal guardian request information, you still have national standards recommend, but now as the state of Kansas, we require consent. So I feel like that needs to be removed. If I'm understanding what this document is for. It's no longer a suggestion, since we require consent.
Okay. Yeah, I guess I could have changed the wording, and I see where that could be confusing. You said on page 23.
Yes. Well, I guess it says 15 in the corner, or page 23, but 15 in the corner.
Oh.
Sorry, I think it might be off for you.
So 15.
15, page 15, sorry. Is that right?
Yeah.
Okay, sorry, 15 for your page. And then I think, so my other suggestion would be, if you felt okay with it, then appendix E, you could put like what the screenings, the carve out for the screenings of the bill that are okay, that can be done without consent, since they are specifically listed in Senate Bill 287.
Okay, my concern is this is specifically on medication guidelines and it has nothing to do with the screenings. I mean, we cover that information, but this is specifically medication guidelines. Therefore, I didn't feel that we needed to do the whole law and everything. This is just a resource about medication administration.
Okay.
Rick, did you have questions too?
No, I applaud you for adding that. I just, from what I've read, come to the meeting today, it seems very thorough. So I thank you for adding it because I thought that was a big miss last time we're together, but it's an important part going forward for medication administration in today's environment.
And then I just had a couple logistical things. So under reviews on page 11, the list of original reviewers, just if Diane Glenn is listed in there, she's no longer part of the Board of Nursing. Let me see what that is for you. It's page 3 for you. Oh, I think you're muted.
That was just left in there as historical because everything, it was originally written by the previous people. We can, if you prefer us to just take off any notifications and just leave her name, but we don't want to lead people to think that our group wrote this entire document. We are just updating it as we have made some revisions. I mean, you know, we're all school nurses. We're not, those of us on the board, we're not in the academic setting. So we're just trying to do something for practice setting for school nurses. Tara, if you feel free to jump in if you have any other take.
Correct, because we didn't recreate the entire document. We made additions due to existing laws as well as current practices, but we kept all the original authors. We can change that to original reviewers on our page 3, your page 11. We can put original reviewers.
Yeah.
Would that make more sense?
Yeah.
Yeah.
Okay. And then, so I guess it's your page 12, page 4 of the actual document. You'll see that this says 2025 revisions were completed by the following, and then reviewers, Dr. Taryn, and then we would put KSBN as well after your approval.
And we were just curious, was there any attorney review of this that happened?
Our organization doesn't have an attorney to review that.
Thanks. You know, the newbie has to ask all the questions. Right?
Absolutely. No, it's totally fine. It's a good question.
Let's see, and then page 13, which is page 5 of yours, states that the 2025 revision was developed to accommodate the legislative changes regarding medication in Kansas schools. I think that's what you were talking about.
Yes.
Okay. All right.
Correct, because we originally started this with knowing that naloxone was already on board, that albuterol was being looked into at the time we started it. It has been approved since. So, and then the more a small group, as you are probably aware, the more you look at a document, the more you start scrutinize every little sentence and word. So this took a lot longer than we originally wanted to, but in the long run, it ended up working out because albuterol just got passed. So, and there was additional changes. So, everything happens for a reason.
Yeah. No, thanks for your work on that. Greg, did you have a comment?
Madam Chair, I had a question about the emergency drugs and the albuterol that just got approved. Typically, I'm sure you're talking about the small compressed multi-dose inhalers, albuterol, or are you talking specifically about nebulized albuterol? Which form are you talking about?
Well, albuterol comes either way. It honestly would depend on the overseeing physician and pharmacist, how they want us to prescribe it. You can do either way. If you do the multi-dose inhalers, what you could do is have a spacer with individual throwaway mouthpieces. And after every use, you would wash and sterilize the spacer itself, if that makes sense. After every student, every patient. If you use a nebulizer, you would have to, the tubing itself, in general, tubing is not reused anymore. That would be thrown away.
My question was more related that this was part of your emergency preparedness or emergency access drugs, like your naloxone, et cetera.
Correct.
So that's why I was assuming that it was the aerosolized inhaler form, which you asked me, and was that detailed? I'm not sure if I saw it specifically, but was that detailed as well as you did with Section R on the G tubes for make sure everybody knows about the administration for the individual doses on those emergency drugs, like the albuterol?
In other words, instructions on how to instruct a patient to use it?
No, I'm more concerned that you're taking a multi-dose vial, like you said, that is normally done for a single individual when purchased. Now you're going to be using it for potentially multiple people, and how that is going to be done since it is not normally done that way.
Okay, I see what you're saying. So basically how I explained it, you want that put into the handbook, that either you have a spacer with.
Be stated in that. Otherwise you may have somebody handing the albuterol inhaler around the room and, that's not not the way it would be done. And that's being facetious, but,
No. No, I
It's just a-
understand. That would be next.
yeah, and sterility and trying to keep it, because of all the drugs you have in there, I would foresee that one being one that would be utilized more frequently.
Sure, sure. So we can write that up. Do you prefer us to email that to the committee and have the committee email us back with an approval, or do you want to wait until your next meeting?
Do we have any more?
Are there any other?
Yeah, is there any other concerns?
Oh, Patty, those were two.
And
big-
I-
are we-
I can also address that. So it's not as thoroughly done as the other section because the Kansas State Board of Nursing or the Kansas Association of School Boards, they have also went through guidelines that they're recommending in schools. This was a brand new law and we haven't had like any time to work with this. It was just getting implemented and they hadn't gave any guidance yet. And I mean, all we're doing right now, I feel like, is presenting what the law is. We don't have the guidelines from how school boards want it to be, but we do have it specified that that the law says that they're basically meter dose inhalers. They're not nebulizers that is going to be available for stock.
And I guess for me, I'm just thinking of it more from a clinical practice standpoint of the nurse with the child in their office at the school. How am I going to do this if I maybe have two of them there? What's the guidelines and process, and be able to refer to something like this for some information. And like I said, I thought your information on the Mickey buttons and the G tubes for the children was well done and with good references. And I think it would be useful, just as a suggestion, to have something like that in there. Because I'm thinking you're wanting to use this as a guideline. Is that correct or no?
Yes, that is correct. So we can do that. It just unfortunately won't be available for school nurses at the beginning of the school year. Because we'll need to come back and get approval from you guys first, it sounds like.
I don't think, right?
Do an email them. Yeah. Yeah.
Yeah,
And then they can have it back before school starts.
yeah.
I would think so. And the way you described it in terms of what your process is planning, that seems reasonable and especially if it is the standard with other schools or things that you've done to review that seems very reasonable. But as a practitioner on the other end, it'd be nice to have when school starts to know what to follow.
So Angela, you can just email with the revisions to Linda.
Okay.
And
Okay.
that way, I'll give it to the committee.
Yeah.
Yeah, the committee will have it and then you can have it when school starts.
You can have it back before school starts.
Okay. That's the ideal, is to make sure, because I know some districts are wanting to get something started. Yeah, that's why we're pushing so hard to try to get it out. Thank you. We can get that done.
Thank you. Thank you, ladies. We don't need a motion on that. Okay, thank you again. All right, next we have new business, and this is going to be a presentation by Kansas Midwives Alliance. Deidre DeBrado is with us here today, and her CV begins on page 110 of the packet. She is a certified professional midwife practicing in Andover. And it's correct that you've got a presentation for us today, is that right?
I'm thinking, I'm gonna pull it up, right?
Oh, you did that.
Can you see right here? Okay, so the first slide's gonna be just my CV. I thought I would just kind of start by telling you a little bit about me personally. She's right, I live in Andover. I grew up in Colorado with my parents and my sister. I've spent the better part of my life actually in Wichita. And the last 30 years has been in birth work. The last 10, basically the first 10 years was being a student and a labor support person and a birth assistant. I've been a primary midwife for 23 years. I've delivered just short of 1,100 babies. And so I want to tell you a little bit first about me personally. Obviously, I think it's important that we know who we're talking to. I am married for 32 years. My husband's Jerry. We both are super committed to doing just exactly what you guys are doing. My husband's a chiropractor. He's been on the Board of Healing Arts for 10 years, just finished as the president. I serve on the Kansas Midwives Alliance as a vice president, done probably 10 to 15 years on that board over the last 30 years. And we have raised 9 children, and the oldest is 36. And the youngest is 16, so we're almost empty nesters. Almost there. Then we have 6 grandchildren, and then we're gonna have 3 little girls this year, identical twin girls. So my sons and his wife are having, and then I'm going out to Phoenix to do my daughter's birth at the end of the month. So our family is super growing. I have a picture. Are you able to put that up, or?
I think he's working on it.
Yeah, as soon as we've got the.
I have the presentation. That's it.
No, you should have an email.
I mean, that's all I'm gonna really be able to share, due to like the technical end of it.
Okay, no worries. I'll bring up, I can send it on my thing later, but anyways, okay, well then, just moving on, go ahead and bring up that first slide to the PowerPoint then. So it sounds like, first of all, thanks for having me. I'm not sure exactly who invited me or how or what the process was for that, but thanks for having us for sure. Definitely love speaking to communities and the community, and this is definitely one of my passions for sure. So hopefully today what we're going to accomplish is that I'm going to answer your questions about the role, function, education, certification services of certified professional midwives. It's obviously a field I know well, been doing it the better part of my adult life. And then go ahead and move to the next slide. So obviously we talked about the objective that you guys are looking for. At the end, I would love to hear how we kind of got invited and kind of how this information is going to be useful to you guys. And I want to leave room for some questions, of course. And then, you know, basically the relevance is that we're always trying to build a healthcare community. We know that we have some really serious like OB deserts in Kansas. And so anything we can do to grow this field is super important. Next slide. So I want to start by saying a little bit now about what I do. So I own Wichita Birth Assistants. We are a midwifery group of, right now we have 3 midwives. They're all CPMs. I've had CNM, CPMs. We had 5 previously serving. We have a couple of staff members and we have a handful of birth assistants. I am also a consultant, very, very part-time. It's kind of my hopeful retirement job, which hopefully is around the corner, at Midwifery Business Consultation. And what we do, it's a national organization. We train and we help midwives, CNMs, CPMs, all midwives all over the United States start their business in midwifery or grow their business or just kind of help maybe refine their protocols or risk management or just the financial business piece. A lot of midwives feel like the business end is something that they aren't very good at, but because we know like home birth practices are just growing exponentially all over the nation, it's definitely something that's keeping me busy. I'm a former member of the Kansas Maternal Mortality Committee. That is definitely a big part of my passion. The mortality committee, you guys, some of you are probably very familiar with it. It's a very large committee. Usually we have around 30 to 40 people on that committee. It's run by Kansas Department of Health and Environment. And basically our job is to evaluate every single maternal mortality that happens in our state. And so it's really super heavy work. I actually just resigned approximately a year ago. It was a lot. And they're doing super great work. Obviously, you guys know that we've gotten a huge grant in our state to kind of help improve maternal mortality. So I'm incredibly excited about that and to see how that's going to all play out. I'm US Bridge midwifery certified. So US MARA is a group also you guys may be familiar with. It's an organization that kind of brought all of the midwife stakeholders together and said, hey, what can we do to sort of build a foundational baseline for best practices? And so the Bridge certificate is just something that says like all midwives have kind of, they can basically go through this process to become certified and that they've got all of these really basic necessary components to their education. So my backstory is that after I had my first daughter in 1988, my sister had a baby in 1991. She was young, 21 years old, and it doesn't matter how long ago it's been, 34 years, it's still super hard to talk about. But basically she was in labor, low risk, healthy mom, and she had a fatal amniotic fluid embolism and she died during labor. Her little boy was life flighted to Children's Hospital. He spent 3 months there. He's 34 years old now. He has severe cerebral palsy. He's continuing to be raised by my parents. My dad's 82, my mom's 77, and they're involved in his direct day-to-day care. So he's my reason. And basically, I think when that happened, I would just say, like, my faith is a big part of my life, and and it just set the trajectory of my life to be strong and courageous, and to basically go into this world and into our country and be like, what in the world makes birth safe? A 21-year-old girl shouldn't die. And I think if we look in hindsight at the maternal mortality problem in our country, we can see that that's when decline started happening in the 90s. And now we have an astronomical problem. So that's why I'm doing what I'm doing, why I got involved in midwifery and how I got here. So I'm super dedicated to serving women, being emotionally present at their birth, and yeah, I always feel nervous talking about her, but anyways, I love to just be with women while they're having babies, and just making sure that they know what their options are, and that they're safe, and that their babies are safe, and keeping myself up to date on all the best practices for having babies outside of a hospital, even though sometimes we end up there. Next slide. So basically, what is a professional midwife? Okay, I didn't know I was not gonna be able to kind of glance at my notes here, but maybe I feel better. Yeah, okay. So obviously I want to start by saying, what is a CPM? Because I realize there's probably people who have absolutely no clue what a CPM is. So we are certified professional midwives. We are certified by an organization called the North American Registry of Midwives. And basically, our focus and our scope is wellness-oriented care for women who are having babies, even though we also do some like well woman care. Mostly we're taking care of women who are low risk, healthy during their pregnancy, labor, and delivery. So basically the scope is mostly defined by NARM, but also state regulations. And so basically our key responsibilities are doing pregnancy care, labor and delivery, postpartum, newborn care, immediate postpartum, and then postpartum through 6 weeks. I'm going to talk a little bit more about it on the next slide. In many states, there is limited prescriptive authority, and that varies from state to state. And then some of the states allow CPMs to administer medications, so like antihemorrhagics, vitamin K, antibiotics for group B strep, IV fluids. Those are the main ones that a lot of states have. I mean, obviously there's limitations to what midwives can do, should do, and are doing. And so I can go into that, but I'm gonna move past that because obviously we're not doing C-sections and taking care of high-risk women. Next slide. So our prenatal care is obviously very holistic. And we are very wellness oriented. We are super motivated by informed consent and refusal. And I would say the majority of our clientele are looking to have a say-so about what's going to happen at their birth and how it's going to happen. Every prenatal, the first one's an hour and a half long. And basically what we're trying to do, we use an electronic health record, just like the majority of healthcare providers. We're going through their chart. We're trying to determine, are they a good fit for our style of care? Are they actually low risk? If they meet that qualification, then we're going to go through some documents with them. One of them is an emergency care plan. That is one of the things that NARM requires. And that just means that we're having a safe face-to-face conversation with them about what it would look like if we had an emergency transfer during a birth. And then we're gonna, be doing all of the things that normally anybody would do if they're gonna see a provider during their first visit. So that could be a lab, that could be, listening to baby, of course, taking mom's vitals. Those are gonna be the main things. We're always, as I said, we're wellness oriented. So we're talking about what's going on with your diet, exercise, sleep, energy, all of the things that kind of make them them. And then the other flip side is the same thing they're going to have done in any provider's office. Like I said, measuring fundal height, what's going on with your blood pressure, what's baby's heart tones, all of those kinds of things. And then during the labor and the birth, we're gonna go to their home while they're in active labor. And our job, once we get to the birth, is gonna be similar to probably any experience that you guys have had, and also very different than any experience most people who've delivered in a hospital have had. The biggest piece is obviously we're there to make sure that mom and baby are well. So we're doing intermittent monitoring of fetal heart tones, we're checking mom's vitals, but we're also there to help facilitate kind of non-allopathic methods for pain management. About 50% of our moms are gonna have water births, the other 50 are gonna be land births. No one in our practice ever delivers really like in a lithotomy type position. Most moms are standing forward leaning or hands and knees. And so our job is really just to facilitate a normal, natural, healthy birth. And then our postpartum care starts with the immediate postpartum. So once baby comes out, it's gonna go straight up on mom. So some things can happen in that first hour after birth. I'm sure you're familiar with that. So we're monitoring to make sure mom's not bleeding too much. Our whole team, including our assistants, are certified neonatal resuscitation. So we're starting that if we would need to, but mostly we are just there to respect the golden hour, skin to skin with mom. Most of our moms are breastfeeding within about 20 minutes. And after that first hour goes by, the second hour is gonna be just kind of us getting them up to the bathroom. We may have to suture them if they had a perineal tear. And then we're just making sure that they understand their postpartum instructions. So we're with them about 2 to 3 hours after the birth. And then after that, we're gonna go back and see them at their home in 24 hours. And at that visit, we're gonna offer all of the state mandated testing. So you guys, again, are probably familiar with this stuff. So vitamin K, or not vitamin K, we'll do that at the birth, we'll offer that at birth. The newborn screen, the critical congenital heart disease test, and then basically at that appointment, we're just, how's everybody doing? My friend likes to joke, like, we're like, oh, how's dad doing? Because, he's usually kind of overwhelmed by then. And so we're just seeing if breastfeeding is going well. We're checking to see like, what's going on with baby's weight loss? How concerned do we need to be? Evaluating jaundice, all of the normal things that you would have on a day one visit. Then we're gonna have them back to our office between 1 and 2 weeks later. Again, to evaluate weight gain, weight loss, check in on mom, how's she doing emotionally. We always use the Edinburgh screen during pregnancy to kind of get a baseline, and then we're checking in on mom again as far as like, how are you doing? Any depression, any baby blues coming up? And then we're gonna see them at 6 weeks. And that 6 weeks appointment is an hour long, again, just newborn exam with baby, another one, we do that right after the birth also, I think I forgot to say that. And then this is gonna be another newborn exam, and then also just kind of head to toe, how's mom doing, what's going on with her tear, did it heal up properly, how's her diastasis recti, what's going on with her vitals, and then we're gonna be releasing her from care. All along, I'm not gonna go into the educational role, I would just say that midwives are experts in education about labor, delivery, postpartum, all the things, and it's definitely something we major on along the way. Next slide. So educational pathways, obviously, that is probably a big part of something that you guys are asking here. The majority of midwives nowadays are going to a MEAC accredited 4-year bachelor's degree program where they are just basically getting a degree in midwifery. And then they are going through an apprenticeship with a certified preceptor through NARM. So I'm a certified preceptor. I've precepted a lot of students over the years, many. And so what they have to do when they come in for their preceptorship is usually they're still in school. And they have to do 55 births under supervision. That's gonna be actually on the next slide. But they also have to go to all of my prenatal appointments. They have to go to the births. They have to help with the immediate postpartum. They're just immersed in midwifery. And it usually takes a good amount of time depending on your practice. A lot of students that we get don't end up spending as much time doing it because we're a really busy practice, so they're able to get done a little bit quicker. But some practices it could take just a little bit longer. So their core studies obviously are going to be really similar to a lot of healthcare providers, so anatomy, physiology, pharmacology, cultural competence. And they're just developing a lot of skills with their apprenticeship. Next slide. So the certification process is obviously that accreditation piece through a MEAC accredited school. I am going to touch on the PEP process because that is how a lot of the older midwives, like myself, became midwives. And that process was really one of individualized self-taught education and like picking up a class here or there, maybe like a medical terminology class at the local college. Maybe it was going to a weekend CEU course that other midwives were getting recertified in, and you were just learning at that. But that PEP process basically was a very tedious process of having basically a lot of books that you had to study and learn from. And then you basically did your apprenticeship, where you also got a lot of academic training and a lot of hands-on experience, and then you sat for your NARM exam. And that's basically what I did. I kind of did a hybrid where with a little bit of the school, because schools were really starting to come about more back then, like more schools were opening and the process to go through a school was just starting to open the door. So I kind of did a bridge situation. And then basically they had to do that documented clinical experience that I talked about and then pass the exam. And then midwives who are already certified are required to do continuing education. So obviously regular updates to maintain certification, stay informed on best practices, 25 CEUs, neonatal resuscitation, CPR, and then 5 peer review hours, and then every time we have to do cultural competency. Next slide. Yeah, so I think this is going to be the main slide where I want to talk about Kansas specifically, because I think that's probably the core of the questions that you guys have. So CPMs, as I said, are licensed in 36 states and District of Columbia. Specific scope of the practice varies state to state, as I said earlier. But as far as Kansas goes, basically what happened, I was just starting my midwifery career, so I know this story very well. In 1993, you guys may be familiar, there was a case, Rubke versus Board of Nursing and Rubke versus the Board of Healing Arts. That was a case where there were 2 midwives who delivered a set of twins. So one of the twins did not make it, and both of those organizations filed injunctions against them. They were restrained. They went through a legal process, and at the end of the day, after that legal process had kind of went through all of the steps that it needed to go to, it went to the Kansas Supreme Court. And the Kansas Supreme Court ruled unanimously that midwifery in the state of Kansas was not the practice of medicine, nor was it the practice of nursing. They basically said childbirth standing alone in and of itself is not a medical condition. So basically that is the legality of what is happening with certified professional midwives in our state, is that we are legal by what we call judicial interpretation. And so I am going to talk about the pros and cons of that, but basically what that does is, well, I'm trying to decide if I want to go into that next.
May I interrupt just one
Please.
question? I'm just curious, and reading through this, is that you're licensed to practice in 36 states, so a licensing, so in the
Exists.
licensings in the state you're in,
There's no
Okay.
license in the state of Kansas.
I know,
Yeah.
no, I'm just talking about, I'm just doing a contrast and compare.
Mhm.
So I heard what is practiced in Kansas by your definition of what you said, but just curious in the other states.
Yeah.
What licensing do they have? Who do they report to through the state? Do they report to the State Board of Medicine, the State Board of Nursing? Where is the most common? Just curious about how those particular states.
Yeah, that
have
is
it
such a
work.
good question. Most of them have standalone boards. Yeah. So I think that's part of, you know, the caveat of Kansas. I think there are a lot of midwives that it's kind of split, you know. I think that a lot of us are like, hey, you know, that's something we should explore. It's something we talk about on the board a lot, is licensure, because there's a lot of pros and cons to licensure. Public safety is obviously one of the biggest pros. I think, go ahead and go to the next slide, and then we'll dig into that a little bit more. This is actually, let's skip this slide because you guys know what CNMs do, and I'm gonna hopefully explain what the difference is. And so basically, Okay, I'm gonna actually go one more slide and then come back, since we're gonna, and that way we can go ahead and talk about it. So basically, let's talk about the challenges. So the challenges are that obviously there is no licensure board. So that's difficult. I mean, that's a difficult situation for the public. We see it in our own practices. We have, you know, sometimes midwives in our own community that we know, like, because it's a small, very small community, that never really had any training, but they can call themselves a midwife because there is no limitations, no licensure. So we, my group in particular, has spent a lot of time establishing collaborative care. So for example, I'll just, I can basically call either hospital at any time. I can say my name, they know who I am. I can call the laborist, I can say, hey, I've got this problem going on and I'm coming in. I can make a call directly to the NICU will directly admit my patient if it's a baby. So we've spent a lot of time in our community really building and collaborating relationships, because we know as a nation, that's what makes out of hospital and midwives safe, is having good collaborative care. So we have that, but there's nothing to say that the person next door is doing that or has that, because the board that we have is a voluntary board. And in other words, we don't have disciplinary, how would you use that?
Processes.
Yeah, we don't really have disciplinary processes. We can voluntarily submit to that, and a lot of midwives do.
I was just going to say oversight
Yes,
Mhm.
yes,
of
exactly.
the standard.
Yeah, absolutely. And that's a lot of what I do in my work with midwifery business consultation, is really help midwives establish protocols and follow their protocols.
Melissa? did you
I
have a
have a
question?
quick question.
Yes.
So when you say you can call either hospital, now is that just born out of a relationship?
Yes,
Or do you have some type of contract?
no,
No contract, it's just a basic phone call.
yes.
Do you have privileges or you hand over that to the
As soon
hospital?
as I walk in the door, I hand it over, but I stay with my patient and then I give a report to the physician. I mean, we are incredibly involved when we're in a hospital setting. We're really incredibly involved. And we really, I know that what we have in Wichita is not what a lot of midwives have around the state. But we really have I could call the laborist and say, hey, this is XYZ. In fact, I did. I had an actual placental abruption at home 3 years ago. It was terrifying. I never thought I would see that, but I did. But I was able to call. I said, I'm pulling up at XYZ door. I've got a placental abruption, open up the OR, and here's what's happening. I brought her in and on oxygen. We got her in there. Mom and baby are perfectly fine, but it's because we have an excellent, well thought out protocol, plan, and connection. And we work with the directors of nursing. We do regular meetings with them. We say, hey, what are we doing well? What do we need to work on? And they say, hey, what do we need to work on? You know, and we sit down and we really line things out. And I would say, like, one of the hospital, I mean, they're both fine. One over the other is a little bit, what would you say?
I'm not sure where you're headed.
Just kind of like, the other one. Like, I would just say, like, we have maybe a little bit more elevated, better relationships with some people at one over the other. But I have the laborist numbers at both hospitals.
I think
And
it's because we worked with the nursing board, and the nursing board is actually collaborated with the relationships with the laborist between us, and we know exactly what we need to do 100%.
yeah, so she means like director of nursing, like not
Yeah.
nursing board.
Yeah, sorry, nursing, yeah.
Yeah, the nurses that are on staff there.
Well, and you're hitting on all the reasons why you got invited. And you know,
Okay.
this was truly for us to have an educational understanding.
Yeah.
And I appreciate how you're highlighting like differences in practice, because I think that's probably where our concern has been. Because we know it's not standard and
It should be,
you know, if so,
yeah.
like, I don't know how to solve that problem, especially if we don't have jurisdiction over that.
Yeah.
So it's helpful to know that you said, so it's a volunteer, so maybe talk about that again, it's a volunteer.
Cynthia is the president of the KMA, so I'll just let her kind of.
Right now?
Yeah, go ahead.
We just are a voluntary board, and we actually are, midwives can either participate with us or not in the state of Kansas. And do I need to move up, or it won't take me very long, but I'll be happy to do that. They can participate or not. Some midwives vote, right? do not want to participate with us. We really are knowing, like, because nobody will license us, even though there's some of us that would really like that, then we have to say we have to govern ourselves and we have to be above board with what we're doing. So there's some that will not be part of our board, our membership, organization. And so there's time, from time to time, there'll be a doctor who calls us, a pediatric doctor who calls us and says, what do we need to do? We
This is what
refer-
happened with the transfer, anything we can do about it. We've had parents,
Yes.
call it grievances.
And midwives
Yeah.
call with grievances about other people
Other
practicing.
Yeah.
And so we can refer them to, are they part of our membership? And if they are, they can definitely give us their concerns. And as the board, we will go over those and we will try to make a plan moving forward with them. We've gone to EMS, we've gone to, I mean, we've done a lot of work in our community for sure.
Yeah.
So, yeah, does that answer the question?
Yeah,
Okay.
thank you.
Yeah.
What percentage of practicing midwives in Kansas are members of your board? Would you
I would
say?
say, I would say the biggest majority of them.
Yeah.
I would,
Like greater than?
80 to 90%.
I would say, yeah, I was gonna say like 80 to 90.
And even we'll have sometimes situations, we had, we do a lot of education is basically what we focus on, is offering CEUs, education, accountability, peer review, public, just public awareness, that sort of thing. But, you know, we recently had a case where, we were at a meeting of a lot of midwives, and a midwife was sharing a story at a round table, really simple, similar to this. And I was like, what's that girl doing? Like, what's she should be doing that, you know? And thinking like, what's happening there? Like, what happened with their training? And I mean, you know, I'm very familiar with all the midwives. All the midwives in my area were trained by one of two midwives, and then everybody after that mostly is trained by me. So this midwife was not from our area. And so we just reached out to a midwife in her community and we just said, hey, you know, I don't know if you heard what she shared, but she obviously has the idea that it's safe to do XYZ at home, and maybe she needs some mentoring. And what if you reached out to her and said like, hey, so she did, she went to lunch with her and had a talk with
Was
her.
well received.
It was very well received. She's like, oh, I had no idea. The midwife that trained me uses XYZ all the time to whatever. Let your imagination run.
And then she called us to
Yeah.
say, this was the way I was trained, but I really appreciate everything you guys have said. Could I come and shadow
A
and work with
preceptor.
you all?
The
And
precept with
yeah,
And so I think that, you know, midwifery has changed a lot, and obviously the numbers of babies being born outside of hospital is growing astronomically.
does that answer your question about the board?
Yeah.
If you have said there, I'll have cut back up, but
Yeah.
I'll let you finish your presentation.
Thank you. Yeah, so I think that, you know, I think when we look at what are the pros, the cons are we're not regulated, and the pros are we're not regulated. You know what I mean? And so like, when you look at, you know, our sisters, who I have had literally put on public, huge public people coming out at a park for the nurse midwives in my community, because it's terrible what's happening to them.
Well,
We
and
have-
we don't have certified nurse midwives in the Wichita hospitals.
None, zero. We have a very serious,
Okay,
political problem down there. They're great to take care of us. They're great for us. They want us to bring it. They're fighting over us coming to their hospitals when we have transfers. But like, will they hire a nurse midwife in their hospital? Absolutely not.
Do you think part of the problem is the difference in education levels that's required, and
I mean,
did
really,
I not hear you say that some of them can do the midwifery training with a bachelor degree?
I mean, that's, a lot of the CPMs do have a bachelor's degree, and the CNMs obviously have a master's degree. But I would say like time-wise, it took me 8 years to become a midwife. So, I mean, you know, the time that you put in, we had a nurse midwife that worked in our office for several years. She was in the hospital for 18. She was the only nurse midwife in Wichita for 18 years. And they decided they didn't want to support the model anymore because the home birth midwives were growing like crazy and her practice was as busy as could be. So I said, hey, come join us, or I can help you get a business going. That's what I do for a living. She said, I'm going to join you. She was close to retirement. I mean, she brought 50 patients with her. They were like, oh, we don't care about the hospital. We just like you. We'll have them at home. We don't care. So, you know, they came. over, and I mean, we got 55 patients kind of like overnight. And then she went on to, we had to onboard her. So we had to teach her how to do home birth. She never done that before. She never done a water birth. Her first water birth, she actually got in the pool with the patient. She didn't understand how to manage the dystocia by getting the mom out of the pool. So she got in the pool. She was soaking wet. We had a lot of fun with her.
That was funny. That
It was
really a
funny.
Story.
She grew our practice a lot
Yeah.
in a lot of like standards and a lot of like helping us realize like, okay, one of us can't have this standard. One of us, like, we're a group, she was really great for us. But at the end of the day, she told us she ended up becoming a CPM and let her CNM license go. Because one, I mean, the insurance is unreasonable. It's not doable. It's not sustainable for a home birth practice for somebody who's not getting paid for a large corporation. And so she let her CNM license. She did the CPM and she said, I'll be honest. She said, I think that CPM thing was harder than the CNM thing.
Talk about the test.
Just like the
And
testing,
achieving.
the number of skills, the number of births. I mean, you have to go to more births as a CPM before you can actually be a midwife than you do as a CNM. And that was surprising to her. She was like, what in the world? Like, I mean, we just go do some births, then we show up at work the next day and we're like, oh, how do we manage a birth, And a lot of CNMs are doing that. And, I'm very familiar with what happened with the CNMI thing because obviously my husband was on the Board of Healing Arts at that time and it's very connected with a lot of people that were working towards that and trying to see that come to fruition and what could happen with that. So, we have a CNM in our community right now but she's kind of the only one. And, I don't know for sure what she'll end up doing or not. It's definitely a political problem with the CNMs down there. Like, they're so happy to have us, but man, they don't want somebody actually working in the hospital for sure. And I don't know what the problem is. I mean, I do know what the problem is. They have protocol or, what do you call that? Not guidelines, not protocols, kind of like their overall board, can you help me out? No, not standards, but like policies that say that CNMs can't admit and the laborists don't want to, they have them admit under them. Right. For whatever reason, territory.
It's actually more to it than that.
Yeah.
Because like in the critical access hospital, we had very successful midwives.
Yes,
And
some cities do. Wichita is just terrible.
Most cities.
Yeah.
Yeah, most cities do.
In Winfield, we had
Oh,
two
yeah.
very
Oh, yeah.
successful ones.
Yeah, so Jamie Harrington is a friend of ours. She works down the street.
She's a CNM that
Yeah.
worked in Winfield.
Absolutely, it was wonderful, and but the reason is because CMS regulations, they had to have a doctor sign their practice.
Exactly.
Even though the regulations changed for them in Kansas, we could advance practice nurses. I mean, Jamie's a DMP.
Mhm. She's a smart cookie.
Yes, she is.
She's a smart cookie.
But
I like her a
the
lot.
CMS guidelines, because it's critical access hospital, required that a doctor ever sign so many of their charts.
Yeah.
And
That's super unfortunate because we have all these deserts and all these people who need care and they're driving 2 or 3 hours to Wichita, Kansas City to be getting out of their babies.
Because
then-
of the deserts of OB care
Yeah.
in Kansas.
And we even have a lot of great relationships with some of the small hospitals. I mean, we make it our goal to go visit them and say like, hey, we have a problem, we're in your community, we just want you to know we're here and we're having a birth and who should we call? And they give us a number of somebody and, we call them and say, hey, we're gonna have a transfer and here's what's going on but we also know our place, like we're not.
lobby up a little higher, that's all I'm saying.
Yeah, I know. I've heard that some of that might be changing. I mean, I don't know if that's true or not, but I don't know the whole CMS thing's very.
We really beat it to the ground. I mean, like I would say the two midwives standing here in front of you guys have really worked over the years to try to persuade and find a path for licensure. It just,
Yeah, for CPMs, yeah.
for CPMs, it just is very hard for it to go anywhere.
Yeah, and honestly, I'm not sure because of that, we want it to go anywhere.
Yeah.
Like, I think that's the debate is just like, if we have licensure, like, is that gonna just cut more people out of care,
Well, I say the only thing I'll counter that with
Sure.
is licensure provides consistency.
Yeah.
it provides oversight, it
Absolutely.
provides discipline. And a lot of the things that you described in your success of your practice, I'm not trying to be rude or anything, but are based on success stories as opposed to, I like evidence and, evidence to provide an outcome in terms of a study type evidence.
Yeah, I mean, I
As
think
opposed to, just, good outcomes we've had says, report myself, because my other question would be for everyone that is out there like you, who, and your associate, how many are not that would not report themselves or would not do this, that have been practicing this way? Oh, well, we're not supposed to do that, these stories, like you said.
for sure.
And that's
It's a
where that
problem.
lack of consistency is, it scares me, just hearing about the things you told me. And I think that's my opinion in terms of, and again, to Michelle's point, that's not something we're gonna resolve here.
Yeah,
But
it is
but it's
scary.
But
I
it's,
mean-
that's my concern, and that's what I think licensure does provide for, like, for myself.
I'm
and-
wondering if
and,
the state actually wants that, I don't know who pushes for that, how that gets fixed, or what the path is for sure, but I actually do agree with you, in the aspects of establishing protocols and,
Evidence-based
and I think that a lot of states have really great evidence-based, research to show what their outcomes are and what's happening. I think in general, the majority of home birth midwives have a transfer rate of approximately 10%. Our C-section rate is 2%. I mean, I almost never have a perineal tear. We have a NICU transfer rate this year that's a little higher than usual. It's probably about 5%. But we haven't had any maternal deaths or infant deaths, in my 30 years
That's
of
true.
doing this. So
That's good.
I'm not saying that I can't. I don't want to appear prideful in any way because it could happen to anybody. And
Well, can I add that they were also doing low risk? We risk a lot of people out early on if they
Or
don't.
during.
Or during, yeah, we definitely have, our backup plans for both prenatally and at our birth. But at the very beginning, and I think you'll go into this, they're low risk and we can risk them out, if they're not getting care from us. Like a lot of times at the hospitals, they're seeing people that haven't even had prenatal care, so.
Yeah, so their outcomes are gonna be worse.
Yeah.
And we've seen, my son is in the military and he has a guy that's in his group and he said, Mom, their baby died. And I said, oh my goodness, what happened? And he said, well, she was having a breech baby at home with, I guess, some girl that lives in a community outside of ours. And I know exactly who he's talking about. I was like, oh no, what happened? He said, yeah, the baby was out and head was stuck in there. And then I heard about it from the hospital, because of course, all the hospital people tell me all the bad stories. And so, we do have a couple of people in our community that are practicing and,
We're back and forth across the border.
yeah, from one state to another. And I hate that, for one thing, I hate that it gives out of hospital birth a bad name, because by and large, it's incredibly safe and the research shows that, but it gives midwives a bad name and it hurts the public because, I guarantee you that gal just didn't know any better. She didn't know what she didn't know. And when people come in for meet and greets, I say like, look, hey, there's plenty of midwives in our area. You should interview them all. But here's the questions you should ask, Are they certified in neonatal resuscitation? What do they do for this? What do they do for that?
So I have a question, and
Yes,
when it was brought to us before, we truly, I run for mother baby like a rat.
Okay.
I just do. I'm a cardiac girl, but I will run. If there's a baby or a pregnant lady there, I'm like, no, I can't do it.
No, not that.
So that's why we asked you to come,
Mhm, thank you.
because we need that kind of information, and we did get a lot of information. Thank you very much for that. But so I guess the question back from before and now is what is being sought from us? What is it that we can help with? Or, I mean, I know licensure is a big deal, but
Yeah, I don't even know where to start. Like, honestly, I say that to the board all the time. You guys, I don't even know where to start. That's not my expertise. Yeah, thank you.
Just a couple questions. I live in like the middle of the OB desert, I'm pretty sure.
Oh, no,
Yeah,
Uh-huh.
we don't even have cactus out there, so. So just a couple of questions, because
Yes, sir.
we have an OB unit and I went to them and just, said, hey, I'm not well versed in this at all, but they're coming. So they had asked me some things, and as you've talked, I've thought of some things. So in some of these circumstances, do you guys function as primary and only provider for these pregnancies?
Correct.
Okay,
Most of the time.
okay. So again, you said about 10% make it to a hospital if need be, roughly. You also mentioned a risk, kind of a risk,
Assessment.
yeah, a risk assessment. So again, is that just based off of your guys' criteria for risk of pregnancies and whatnot?
I mean,
And-
NARM sets that in motion to some degree.
And if a patient says, okay, well, I'm mid-risk, but I still want to do this, is that still a doable situation?
Not for us.
Not for,
They.
not for your specific
Group.
group? Okay.
And we actually make them sign a document that says if we say they have to transfer, that they will. And if they don't, we'll leave and call EMS. So
They
like,
have
they have
to-
to be very agreeable. It's a very big trusting relationship.
But a midwife could take, like a VBAC, I work in the operating room,
Oh,
so
yeah.
that's, C-sections aren't my world, but, yeah, I can help you out. But anyway, so like that, if a mom says, well, I'm a VBAC,
Let me give you an example of one of my clients
Sure.
right now. She's had 2 C-sections. And so like that's risking out of our care. So I actually will go and I change roles, more like a doula. And I go to the hospital where we have good collaboration with our good OBs. And I make them feel not afraid of the hospitals, and I let them know that they can have a really great birth there. And I go and support them in that role.
But she does all the prenatal care.
I can do that.
We walk into the hospital, we call the laborist. Our clients are there, they have the baby, and most of the time we take them home in 4 to 6
And we can
hours.
get early dismissal if everything's gone okay and take back over that postpartum care of mom and baby.
So that's one of our plans. If they're not gonna birth at home, then they can do that. And
We're
since,
still trying to give all the midwifery support, but be at the hospital because they risk out of our care.
so there is some collaboration there of saying,
Yes.
you really need to deliver in the hospital
Yeah.
for this.
Yeah.
Okay.
Yeah.
And then another thing they had asked about was kind of the scope of practice of things. So sorry, I always have to look. So as CPMs, you have limited pharmaceutical dispersing abilities. So if you have a hemorrhage at home, you're likely going to a hospital.
no, I mean, I'll just give you a couple of
Sure.
examples for the way that we have prescriptions. We do have Pitocin, we carry Pitocin, not for use before birth, but anti-hemorrhagics for after, if they are having a postpartum hemorrhage. So there are some basic meds that most midwives, I don't know for sure what everybody does, do carry. Vitamin K is required by the state. So a couple of ways we can get that. One is our clients can have a telehealth medicine with somebody like Jamie, because she's GBS positive and she needs antibiotics. So she'll do a telehealth with Jamie, we'll send her labs over, and Jamie will call out her meds, and then mom has meds. And so then she gets those. Another way is that the majority of midwives, honestly, you guys, we deliver a lot of nurses and a decent amount of doctors' babies. So we have
And
personal
anesthesiologists, I
I
like
mean,
those.
everybody, oh, yeah. So we have personal relationships with physicians, and they really are willing, to help us out with that sort of thing. So I would say most midwives are in a situation where they are able to have life-saving skills and life-saving drugs for the purpose of saving lives.
And that goes with collaboration, because of course, like Jamie has to see her client, right? She has to know her history, she has to see her chart, she has to do all that.
Or I call Dr. Scrafford and I'm like, hey, this client's measuring large for gestational age. Can we send her over to you for a sono? Or maybe I send him to the MFM, Dr. Wolf at Ascension, and say like, hey, I need you to evaluate the situation. And then he'll say, okay, yeah, I need to keep taking care of her. Or he'll send her back and say, this is good, like, okay, but where are you planning on delivering? I mean, I had a client recently and she was back and he said, where are you planning on delivering? She was, we're going to the hospital, but we're just gonna finish out, do our prenatal with Deidre. And he's like, perfect, sounds good. So, I mean, there's lots of different options for things. I would say that, the meds question is a hard one for sure, because I don't know if all midwives have the opportunity to do that, but they do have resources. Midwife RX, has staffed Kansas nurses. And so, they call out a lot of meds. if I have somebody that has maybe, bacteria in their urine at their first appointment and they need antibiotics, then I'll just connect them to Midlife RX or Jamie or somebody like that. Or just send the records to one of the doctors and they'll call the script out.
We really appreciate you traveling here and giving us a presentation. I learned so much. I could
Yeah.
listen to more. I know I could.
I know,
I
it's a
know we're
lot.
already 5 minutes over.
I know, I'm sorry.
No,
I
it
was
was
afraid of
fascinating.
that. Yeah.
It was fascinating.
Did-
But before I move on to the next, I want to make sure that everybody has had a chance to get your questions answered.
And what is, I was curious how you guys came to decide to have us talk, like, where was that coming from? Can you share that or?
We didn't know what we were looking at.
Okay.
They kept saying things and I'm like, I have no idea what you're even saying to me. Is there somebody who can explain it to us
Yeah,
a
so,
little deeper?
Like,
Gotcha.
yeah.
Yeah,
You
it
gave,
was.
like, you had a really gracious suggestion, like.
Yeah.
Why don't you
She did it. Yeah.
talk to somebody who knows, because we didn't have any
Because we couldn't
education
pick- we-
at all,
we couldn't-
so.
We
Yes.
couldn't make,
Feel free to
Anything
reach
else?
out anytime, for sure, like, if there's just specific questions, like, we would be more than happy, and yeah, if you guys come up with any solutions about getting to the licensure thing, and you have like highly intelligent people that know how to do that, you just send them our way. Delivering babies and don't ever have to sleep and need an extra job.
Thank you. Thank you.
Yeah, absolutely.
Appreciate it. Thank you. We only have one other item on our list, and it'll be pretty quick, and that is the 5-year legislative statute and regulation review. And as we talked about this morning in the education committee, that's to be tabled. Did I say that right? Is there anything else? Thank you for a great meeting. Learned a lot.
Yeah, we'll hang around here too, if you guys have any other questions, stay here for a few minutes. That's it.
Are you adjourned?
So we're done.
Are you adjourned? Okay.
We're adjourned.